Good morning, everyone. Thank you for joining us for this week's Virtual Journal Club. My name is JP Rito, an endocrinologist at Mayo and co-host of these journal clubs. This morning, we are honored to have Dr. Cosimo Durante discuss the article Real-World Performance of the American Thyroid Association Risk Estimates in Predicting One-Year Differentiated Thyroid Cancer Outcomes, a prospective multicenter study of 2,000 patients. Dr. Durante is an associate professor of internal medicine at the University of Rome Sapienza in Italy. He received his MD and residency PhD training in endocrinology at the University of Rome Sapienza. He trained at the Department of Nuclear Medicine and Endocrine Oncology at the Gustave Rousseau Institute in France. His academic interests include thyroid nodule and thyroid cancer management. He has demonstrated a record of successful and productive research projects to more personalized thyroid cancer follow-up strategies. On his horizon, he contributes to creating a web-based database of the Italian Thyroid Cancer Observatory, which was established to collect data on thyroid cancer management in a prospective and consecutive series of newly diagnosed patients. Our expert discussant for this week is Dr. Amanda La Greca. Dr. La Greca is an endocrinologist, assistant professor of medicine of the endocrine service at the University of Colorado. She completed medical school in Buenos Aires, Argentina, and then trained at Yale New Haven Hospital. And then completed a fellowship in endocrinology at the University of Oklahoma and Memorial Sloan Kettering Cancer Center. She completed the thyroid cancer fellowship under the mentorship of Dr. Mike Tuttle. Her current research centers on the thyroid cancer aggressiveness in relationship to dietary and lifestyle patterns and in molecular therapeutics for advanced thyroid cancer. Her clinical practice is entirely devoted to patients with thyroid cancer, with a particular emphasis on cases with aggressive disease and complicated management issues. Now I will turn it over to Dr. Durante. Thank you very much for accepting our invitation.
Good morning. Before starting this session, I would like to thank Dr. Brito for these kind words in his invitation. I'm really delighted to be today here with you discussing this paper in this virtual journal club. As you already know, this is the title of the paper we are going to discuss. I would like to stress before moving to this paper that this data arise from a national database, the Italian Thyroid Cancer Observatory database, collecting data from several centers in Italy involved in the management follow-up of patients with thyroid cancer, and they collect this data in this web-based database. So today I'm presenting this paper on behalf of all this network of investigators working in my country. Okay, the key issue of this paper is the American Thyroid Association risk stratification system performance. And in this paper, we try to investigate the performance of this system in a real-world setting. Before looking at the data, the results of this paper, I would like to start with some background, highlighting the importance of this tool endorsed and promoted by the American Thyroid Association. The first edition of this system has been published with the 2009 ATA guidelines. And as you can see, there are three classes of risk: low, intermediate, high. And here you can see the rate of risk of recurrent disease. And as you can see in these three boxes, there are several features contributing to this stratification of the risk. These features are mainly histopathological features. So we have the T, the N, the M. But still, we can see also that this system includes also clinical features, like the detection of local, regional, or distant metastasis through the imaging studies. So here you can see the CNCM. And also we have the serum thyroglobulin. So this system includes pathological findings, but also clinical, preoperative, and postoperative features. During the last edition of the American Thyroid Association guidelines, the one published in 2016, this risk stratification system has been revised. And as you can see, what is clear looking at this picture, the panel stressed the fact that the risk of recurrence is a continuum in the real practice. We have patients with a spectrum of risk ranging from 1 to 2% until 55%. And all these features you can read in these slides can contribute in stratifying in more detail the risk from a low risk to a high risk of recurrence. But why we need in our practice this system, this tool? There are several reasons I would like to discuss in the next few minutes. The first one is that we see today too many thyroid cancer. We have an overdiagnosis of thyroid cancer. Here I'm reporting this picture from the SEER database, and I downloaded this picture just a few days ago. And here you can see the incidence rate and the trend of the incidence rate of thyroid cancer in US. And it's clear that moving from the 80, 90 years to the 20 years, we had a rapid increase in the incidence of thyroid cancer. In the last few years, we have stable incidence rates. But if we look at the whole picture, the incidence has been increasing over the last 2 decades. This trend is a trend that we can observe everywhere in the world. This is a picture from a recent study published on Lancet Diabetes Endocrinology, where you can see the incidence rate of thyroid cancer across different continents. Here are represented 26 countries, and there are 2 main features I would like to highlight looking at this picture. The first one is that the observed incidence rate is higher than the expected and is increasing over time, is steadily increasing over time in almost all income countries. The other thing is that this increase involves especially the middle-aged people. This picture refers to women, but we have a similar picture also for men. And the middle-aged are the one more involved in this increase in the incidence of thyroid cancer. The most striking pictures is the one of the South Korea. Why we have this so abnormal curves in South Korea? We know that in South Korea, at the end of the 90 years, they started a national screening program for cancers, including for thyroid cancer. And starting from this year, they started to perform neck ultrasound in the general population. And as a consequence, as you can see, they had a rapid and dramatic increase in the incidence of thyroid nodules and thyroid cancer. This means that if we look for a thyroid cancer, at the end we will find a thyroid cancer, because we are going to detect all the subclinical thyroid cancer present in our neck. If we have an overdiagnosis, of course, we will have also an overtreatment. And actually, if I come back to the picture of the Korea, to the scenario of the Korea, these are the number of patients who underwent surgery for thyroid cancer. And as you can see, starting from the beginning of the national program, they had an increase in the incidence of thyroid cancer, and of course, a parallel increase in the incidence of surgical procedures. And this increase was so dramatic over time that at the end, in Korea, they decided to stop this screening, at least for the thyroid nodules of thyroid cancer. And immediately, over the following months, they had a reduction in the surgical procedures, a 35% reduction in surgical procedures, and also reduction in the incidence of thyroid cancer. But this increase in thyroid surgical procedures involve almost all countries. This is the picture of the US. The years of observation are between 2006 and 2011. As you can see, in these few years, there was in the top line, you can see the increase in the surgical procedure, and there was an increase of almost 30% over these few years, 5 years. But most important, this increase involves especially the total thyroidectomies. Here you can see the line of the total thyroidectomies, and the increase in total thyroidectomy was 12% per year, as compared to the lobectomies increasing only 1% per year. So we had an increase of surgical procedures, an increase in the extent of surgical procedures. And of course, the higher is the number of surgery, the higher is the extent of surgery, and the higher is the rate of complication, even in high volume surgeons. As you can see with the green bar, even in high volume surgeon, the incidence of complication, the risk of complication doubles, moving from a lobectomy to a total thyroidectomy. Again, if we come back to our original question, if we have overdiagnosis, of course we have overtreatment, but we have also a change in the patient profile. In particular, the overdiagnosis is almost invariably associated with an increase in more low-risk cancer cases. And actually, if I look at the picture of the patients diagnosed with a thyroid cancer in the 80, 90 years, here you can see an example of paper in the 90 years, the one from the group of Mazzaferri. Here you can see the stage of diagnosis in these years, and as you can see in this picture, most of the patients at presentation, at the diagnosis, had a regional spread of the primary tumors, while this picture is changing over time. If you look at a more contemporary series of patients, the patients detected with thyroid cancer outside the thyroid gland are lower as compared to the 80, 90 years. And as a consequence, also the rate of recurrences that we observe over the time are lower as compared to the previous series of patients. This is summarized in these graphs. So we have an excess and overdiagnosis, we have overtreatment. Because of the overdiagnosis in our clinical practice, we see a lot of low-risk thyroid cancer patients. So we need to change our paradigms. We need a more tailored approach to our patients. And so we need to move from the old paradigms in which all patients need total thyroidectomy, radioiodine therapy, LT suppressive therapy, and we will say also lifelong surveillance, to new paradigms tailored according to the risk of each patient. This is the reason why we need the risk stratification system like the one proposed by the American Thyroid Association panel. And the American Thyroid Association guidelines, following this approach, they suggest to tailor our approach to our patients, specifically the treatment, according to the risk. So for patient low risk, we may have a less extensive surgical approach, lobectomy or total thyroidectomy. If we move to patient at higher risk, we will treat this patient with total thyroidectomy or lymph node dissection. The same for radioactive iodine administration. No radioactive administration low-risk patients, yes, treatment with radioiodine ablation treatment in patients at high risk. So we have a good tool in our hands, useful for apply this paradigm shift, these changes in the protocol, but still with this risk stratification system, we have some issues. The first issue is that this system has been validated only in retrospective cohort studies. Usually these published studies are studied from referral centers, and so it's unclear if their findings reflect the true performance of the system in a real-world settings. Therefore, the aims of our study was actually to explore if the performance of the 2015 ATA risk stratification system in predicting the response to therapy at a one-year follow-up visit was able to predict the outcome of this cohort of patients. Patients collected by 40 centers, the centers involved in the network I presented before. And the second aim of this study was to explore if this performance of the system was similar across the different centers. So moving from a referral center, high volume center, to not high volume center, not referral centers. So we consulted the database of this database of the Italian Thyroid Cancer Observatory Network. Just a few words to specify in more details what is this database. This database includes patients with a newly diagnosed thyroid cancer, every thyroid cancer, moving from the differentiated, polydifferentiated, and aplastic thyroid cancer to the medullary thyroid cancer. And all these patients have a new diagnosis of thyroid cancer. At the time of the initial diagnosis, the sites and investigators participating to this initiative, they collected the data of these patients into this database. So far, we have this database started in 2013 with one site, our site, the site of Rome, which was the proposing site. And then in the following years, other centers entered into this initiative, into this database. Today, we have 48 recruiting centers and nearly 10,000 patients with a new diagnosis of thyroid cancer. These are the records of our database. These are the data we collect in our database. So the patient's demographics, biometrics, how they diagnose the thyroid cancer, if it was an incidental diagnosis or the diagnosis was clinical, the tumor pathology, of course, details about the surgical radioactive surgical procedures and radioactive iodine treatments, or even the chemotherapy or the drugs this patient may use if they have a refractory thyroid cancer, or if they are advanced medullary thyroid cancer. And of course, we collect the results of the follow-up examinations. As for the inclusion criteria, in this study, we included only patients with papillary, follicular, polydifferentiated thyroid cancer and their variants. And of course, only patients having all the data needed to classify the patient, to classify the risk of a recurrence of these patients according to ATA, due to the ATA system, and to classify the response to therapy at the one-year follow-up visit. We excluded patients with a NIFT-TP. Here you can see the risk indication system. So we used the 2009, including almost all the new variables included in the 2015 risk stratification system. So as you can see in red, these are the data we included in the previous version. Here are lacking the genetic information. BRAF and TERT are included in the arrow of the 2015 ATA risk stratification system, but as not routinely we perform the genetic testing in our somatic sample, tumor samples, we did include this information, at least for this study. And as for the response to therapy, they were classified according to the 2015 proposal. As you already know, the response to treatment are classified as excellent, biochemical incomplete, structural incomplete, indeterminate, according to the thyroglobulin or thyroglobulin antibodies values, and according to the imaging findings. And there is some slight difference moving from patients treated with total thyroidectomy, iridoid therapy, total thyroidectomy alone, and lobectomy. Okay, let's have a look at the results of this study. On the wall, at the time we performed the analysis, we had 2,000 patients having the eligibility to be analyzed. As you can see here, there is the median age of this study population, 48. As expected, the great majority of this consecutive cohort of patients included females. Most of the sites, 3 out of 4 sites were academic sites, and these patients were heavily treated. As you can see, most of the patients had both total thyroidectomy and radioligand therapy. We still have 40% of patients treated only with total thyroidectomy, and we have a very low rate of patients receiving lobectomy, only 3.5%. Neck dissection was not performed in 61% of the cases. Here there is the spectrum of the histology. As expected, the majority of patients had papillary thyroid cancer, and most of these cases were not aggressive variants. The aggressive variants were a minority, for 0.8%. And we have also a minority of patients with a follicular or Hürthle cell carcinoma. What about the distribution in terms of ATA risk of recurrence? As you can see, the majority of the patients had a low risk at the initial risk stratification, the postoperative risk stratifications. They had a low risk of recurrence. We still have 58% of patients with intermediate risk, only 8% of patients with a high risk of recurrence. As for the response to therapy, it depends, of course, on the treatment they received. Most of the patients treated with total thyroidectomy had excellent response. If we move to patients with only total thyroidectomy without radioligand ablation, of course, we have an increase of the indeterminate response, mainly due to the low level of thyroglobulins. And finally, as for patients with lobectomy, as we have a 1-year follow-up visit, they cannot be classified as an excellent response. We need a trend of the biochemical markers, so most of the patients were in the indeterminate response. If we look at the rate of structural incomplete response according to the initial risk of recurrence, as you can see, the higher is the risk of recurrence and the higher is the rate of having a structural incomplete response at the 1-year follow-up visit. And we performed an analysis trying to estimate the likelihood of a structural incomplete response as compared to the excellent response in patients with intermediate and high risk. And as you can see, they have a higher risk. There is an increase of the risk of structural incomplete response moving from the intermediate group to the high-risk group. This increase is significant if you look at the confidence intervals. And also, if we compare the likelihood of less than excellent response, the intermediate and high risk have a higher risk of less than excellent response. Less than excellent response, I mean structural incomplete, biochemical incomplete, indeterminate, as compared to patients, as compared to the excellent response. And this risk of less than excellent response increases moving from patient to low to intermediate to high risk. Here you can see the odd ratio moving from low to high risk patients. So based on these findings, we may say that 80 risk class proved to be a significant predictor of response to treatment. So this system works in predicting the risk of structural incomplete response or less than excellent response to therapy. The other aim of the study was exploring the performance across the different centers in Italy, because of course we may have some biases linked to because we have different case mix population, surgical volumes, different tools across the different sites. So we use a mixed effect model in order to verify if there is some difference across the high volume and low volume centers, and so exploring the so-called unobserved center-specific features. I refer to these features reporting to the brackets. And as you can see in this table, actually the performance of these classes in predicting the risk was similar in the academic versus non-academic centers and across all the recruiting centers. So we didn't observe any difference in the performance of this system in high volume and low volume centers. What are the strengths of this study? Of course, this includes a large cohort of patients, but I would like to stress this is a contemporary population. Most of the studies exploring the American Association Risk Stratification System performance included historical cohorts, while here we are including patients enrolled between 2014 and 2019. These are prospectively collected data, and I'm sorry for this misprinting, include both academic and non-academic sites. The limits, of course, we were able, as this is a young database with still having a low follow-up duration, we were able to estimate the risk of persistent disease at 1 year. We cannot extend this conclusion to the risk of recurrence after the 1 year follow-up visit. And of course, we don't know if this system is able to predict the risk of recurrence for follicular or heart cell thyroid carcinomas, because in our series we had only 5% of these patients, and maybe the performance of this system can be different in this subset of patients. So, in conclusions, the American Thyroid Association Risk Stratification System is a reliable tool in predicting the short-term outcomes in patients with differentiated thyroid cancer, even in a real-world clinical settings. And these results, importantly, are independent of treatment centers. So thank you very much for your attention.
Okay, good morning, everyone. Thank you, Dr. Durante. That was awesome, an awesome presentation after a wonderful paper. So I want to thank the Thank Foundation for inviting me to be the expert opinion after this excellent paper again. And I'm going to touch base on some of the things that Dr. Durante has already talked about. And essentially, after this whole virtual thyroid journal club, we want to make sure that the audience is familiar with this risk that I acted about, that it's an international effort, as we see on this paper. And this effort for those of us who work on academic centers on thyroid cancer, it's really heroic. So I have no disclosures. I did my thyroid cancer fellowship in between 2014 and 2015 when the thyroid cancer guidelines were coming out, the last edition, and I remember the stress of Dr. Tuttle and us as fellows reviewing some of the draft and all the criticisms that the ATA guidelines received at that time. And I remember the first draft got more than 200 and 250 questions and concerns by the reviewers that they had to address. So I think we've come a long way on the management of thyroid cancer and this risk-adapted approach. So it is an evolving approach, and in the past, we used to try to destroy every residual thyroid cancer tissue, and the idea was to improve clinical outcomes, and that was based on really some expert opinions that destroying every occult spot of thyroid cancer was going to improve outcomes on thyroid cancer, and I think that was a wrong statement. And today, like Dr. Durante said, with this epidemic of overdiagnosis of thyroid cancer, then we have to change the approach of this condition, of this disease. And the idea is to just identify clinically significant disease that is going to impact actually on the outcomes of the patient. So now we're being trained and observed a lot of clinically insignificant disease, and we are being more used to just treat clinically significant disease. So again, why is this change? And in the past, we didn't have those sensitive tools like the ultrasound, the CT scans that we use a lot in the US, and disease persistence or recurrence was detected by symptoms and physical examination when the patient would come to your office and present with a lump on their neck. And now we have been detecting these very, very small thyroid cancers. And that figure that Dr. Durante showed about the staging of and the diagnosis of thyroid cancer is really striking, because now we're really diagnosing very small disease that probably was not going to impact on the life or outcome of that patient. So we really went from this traditional paradigm of one size fits all, and where we only had this staging system, which would give us a static approach on the patient with thyroid cancer, that in thyroid cancer wouldn't apply that, because it's a cancer that has a very high survival rate, and we were overly aggressive. So every patient that was detected to have a nodule, we would do surgery, and the surgery would be a total thyroidectomy. And if you find cancer, then you would give all those patients radioactive iodine, no matter how big or small was the cancer, and if the patient has micrometastasis or not. And if the patient was found to have persistent disease, we were offering more surgery and more radioactive iodine and radiation therapy to the neck, and so on, until we did not see anything on our imaging studies or thyroglobulin assay. We were trying to bring those numbers to zero, and you still see patients today that are very nervous because they've been having thyroid cancer for 30 years, and they were diagnosed in the era where the thyroglobulin used to be less than 0.00, and when you tell them 2 is okay, they become very nervous about it on your office. So we are facing this overdiagnosis of thyroid cancer, but again, these are the last data from the CERT database, and we are talking about a 5-year relative survival numbers of 98.3%. And if you look at the line that was shown on one of the Dr. Durante slides, the mortality rate continues to be really flat. So again, this proves that we were overly aggressive, bringing a lot of complications from treatment on those patients. So now we are doing this more risk-adapted approach that really started back in 2009 when the ATA published the different risks, the low, intermediate, and high risk. And then this is a dynamic thing, and it's evolving to prevent over-treatment at this time. And other societies have come up with different risk of recurrence guidelines, like the ATA, the LATS, and the ETA. So we really want to assess the risk and predict outcomes at every time the patient shows up to our clinic. So again, this is the ATA guidelines in 2009, and we had this classification on low risk, intermediate risk, and high risk patients. And in the box of low risk patients, we have the classical PTC. Those tumors were intrathyroidal. They have no local or distant metastases, or at least clinically significant. The resection on surgery was complete. There was no tumor invasion outside the thyroid, no vascular invasion, and if given, no radioactive iron uptake outside the thyroid bed. Then if we go to the intermediate risk patients, some of those patients had microscopic extrathyroid extension, small cervical lymph node metastases. Some of those histologies were more aggressive, and some of the patients had focal vascular invasions. And on the high-risk patients, we were really clear that patients who had macroscopic growth, extrathyroid extension after surgery, incomplete tumor resection, distant metastasis, and inappropriate TG elevation after surgery, those were the patients that we were more cautious and doing closer follow-up. Now, as time evolved, these are the additions to those three boxes, and we started to understand more of the biology of the thyroid tumors, and these are the 2015 guidelines, or the modified 2009 guidelines. And we added much more features, and I couldn't find the color picture, but that arrow is in color, knowing that it's a continuum of different identifiable disease that adds up to the risk of the patient. So there's not clear cutoff. And now with the understanding of molecular markers in thyroid cancer, I think this is going to be a more exciting time, and I'm excited about the new guidelines to be released, which are probably incorporating molecular markers and making this a little bit more complicated for us who treat thyroid cancer, but for the patients it's going to be better as we are being less aggressive and just individualizing the approach of their disease. So the risk stratification in thyroid cancer impacts all aspects from diagnosis to death. And there are a lot of things that the paper that Dr. Durante shows that an effort prospectively to collect the data as they did it is just amazing. And on my next slide, I'm going to focus on this initial data, which we call the broken chair on some countries. Even here in the US, where we think we had a lot of resources and electronic medical records, we have this broken chair that I'm going to expand a little bit more on the next slide. It also depends on what's the experience of the team and the physician treating this. So again, it needs a lot of education of the new doctors and the doctors who trained 20, 30 years ago to change the way we approach thyroid cancer. It's an ongoing data collection. Every time the patient comes for a follow-up, you change that risk, you change this risk stratification, you give a better prognosis, a worse prognosis, you do more testing or less testing, you intervene or you just observe. So you're continually updating the risk. So the aim is to accurately estimate the risk of recurrence of this cancer also to guide the initial management and guide the follow-up of this patient. So in 2017, I wrote this letter to the editor with Dr. Pitoya from Argentina and Dr. Tuttle from Memorial, because we were seeing a lot of these broken chairs when you're not having all the information needing to re-stratify the patient at the beginning. And this could be even because you don't have the op report and they didn't send that to you. Inadequate path report and cytologists trained differently across the country. Absence of reliable neck ultrasounds. On some places, we still get a paper copy of the ultrasound imaging, and we know how hard is that to assess a thyroid nodule, and now on the area of active surveillance, for example, and how do you assess the borders and the lymph node metastases. And then also the absence of reliable thyroglobulin panel measurement and the different assays that are, you know, across the different centers. So when one of or more of these legs are missing, it is very difficult to re-stratify patients. But as you continue to do this ongoing risk assessment, more data on this follow-up of the patients would potentially help you to just get the chair fixed. And that's because you acquire more data that, you know, provides an adequate follow-up of the patient. So even though you don't have all the data at the beginning, then you are able to fix that on future appointments with the patient. So we always start with this static, to summarize what I just said, we always start with this static data of the age of the patient, the size of the thyroid cancer, the other clinical pathological characteristics of the tumor, for example, the extension outside the thyroid gland. Are there any lymph node metastases or suspicious lymph nodes on the neck ultrasound? And then you want to see if there's any spread outside the neck. So the static staging, which is really necessary, it gives you just the idea of how what's the risk of death from this thyroid cancer. And again, if we go back to the slides that I presented before, we know that the 5-year survival rate is very high on thyroid cancer, more than 98%. So this re-stratification by the different societies, we started to put the patients on 3 boxes. And again, the 2015 ATA guidelines added this continuum. So there's no clear cut sometimes if you put the patient on a low, low to intermediate, intermediate to high, and some patients are like borderline to one or other category. And then very important is what's the response to therapy every time you see the patient, and that's the box that you're gonna change. So once you said the patient has an excellent response to therapies, now today on this appointment, and then on the next appointment, you're gonna reassess how's the patient doing, and that's going to guide your treatment, your surveillance, your further testing. So why do we wanna do that? And again, we're overdiagnosing thyroid cancer, we're overtreating. So we wanna de-escalate the therapy on the patients that don't need that. And the main thing is we wanna bring more quality of life to patients, and we want to decrease morbidity secondary to treatment. If in a country like this one, most of the thyroid surgeries are done by low volume surgeons, we know that the implications of the of a complication, a vocal cord paralysis or a permanent hypoparathyroidism are going to impact significantly on a patient's life, on a disease that probably wasn't going to affect the outcome. So every time a patient comes, again, we want to reclassify and we modify the type of frequency of follow-up studies, the intensity of the TSH suppression. We modify the degree of concern of the physician and the patient. So this ongoing risk assessment that is so important, it's depending on the clinical course of the disease and response to therapy, the risk of recurrence and the risk of death may change over time. So the appropriate management requires this ongoing risk assessment and the risk of disease-specific mortality as new data are obtained during follow-up. So the dynamic approach allows us to obtain prognostic information, predict post-treatment differentiated thyroid cancer evolution and the outcomes. We want to develop these cost-effective and follow-up strategies. Lower treatment-related morbidity rates, and we do not want to harm those patients with unnecessary treatment, and we want to improve quality of life for those patients. And we only want to address clinically significant disease on those patients. I want to tell this story that when I was doing my thyroid cancer fellowship on Thursdays, we have these monthly tumor boards, and Dr. Tuttle and Dr. Shaha would grab the microphone, and it's a big auditorium, and Dr. Shaha's fellows would, shake in the front line, and they would be put on a spot and say, okay, would you intervene at this time on this patient? Yes or no? And because Memorial has this traditional paradigm of observing and doing less, since Dr. Mike Tuttle and Shaha are there, the fellow usually would say, yeah, no, I would observe. And then sometimes Dr. Shaha would say, no, you missed the boat. So even though we don't want to do this unnecessary treatment for all those patients that don't need that extra measures, we don't want to miss these aggressive thyroid cancers that were an intensive therapeutic efforts and closed post-treatment surveillance. And that's the delicate balance that we have to do every day, and that needs like a lot of education from physicians and these multidisciplinary teams, which usually we work hard to make sure that we draw a line and we say, okay, now we're going to intervene, now we're going to start TKIs, now we're going to do more surgery, and that is it's a hard line sometimes. Focusing on the paper that Dr. Durante published with his wonderful team, I really want to congratulate this awesome effort from all the country, because I know this requires a lot of effort from the people who designed the paper, and a lot of education for especially the non-academic centers. So it's really an awesome paper, and I have a few things that I want to go over. So I think it's amazing that this is the first prospective study evaluating the ATA risk estimates in predicting 1 year differentiated thyroid cancer outcomes, and that's very, very valid. It's a multi-center study. It's a large number of patients, more than 2,000 patients. Those are a very large number of patients. It's very heterogeneous, and they had 40 diverse healthcare settings, and the fact that they included non-academic centers it's very it's great. I like that they included patients with total thyroidectomy plus minus radioactive iron or lobectomy, even though they were a small percentage, but I like that they also included those patients. And this mixed effect model, which they use for center heterogeneity, it's great. So they detected that the non-academic centers perform as well as the academic centers. So cons of the study, which are not really cons of the study, but a little bit of observations here. It's a short follow-up, and we know that thyroid cancer persistence/recurrence, it's mainly on the first 2 years, and if we want to extend that, it's on the first 5 years. I'm sure they keep that cohort to see what's going to happen on the next 5 years. It's only on one country, and I'm curious to see how they educated all the crew of physicians or other healthcare providers to make this heterogeneity homogeneous now to make sure that the data was accurate. Most centers were still academic, 3 out of 4, but still very valid that almost 10 of those centers were non-academic. And I put it between parentheses because they self-criticize themselves for including FTCs, follicular thyroid cancers, and Hürthle cell thyroid cancer. But I think we have to start including those histologies so we understand more. Most of the retrospective studies that were done were excluding those variants, but I think including those it's going to be adding to the knowledge of how patients without histologies do. So I put that between parentheses because I think that's also a good thing that they added more, and I'm sure they have a subgroup analysis there. So in summary of what I just said, we have the risk-adapted approach management of thyroid cancer, which everyone in this world should be doing at this time to approach this disease. We have the initial static risk assessment, as we said, and those are going to guide us on the initial treatment and early follow-up recommendations. And let's continue to do this dynamic risk stratification, which requires a lot of effort from the team treating the patient and from the patient per se, and continually modify those risk estimates as new data becomes available. And again, reevaluate management plans, and then we say observe or intervene, and we go back to the dynamic risk stratifications, and we re-stratify the patient every time we see them and we obtain new data. So I'm going to leave with my last slide, which shows that out of all the risk stratification models, which even on this last have the ATA risk, we have the dynamic risk as the best prognostic informator for us. So we have to see that all those models on the left are giving us less than 40% of prognostic information, but if we continue to do this dynamic risk assessment, we improve that to more than 80%. So the ongoing risk stratification and this dynamic approach of thyroid cancer has to be done. And this is my last slide. Thank you for this kind invitation, and I'm happy to take any questions.
Thank you, Dr. Durante and Dr. La Greca, for those wonderful presentations. Dr. Durante, I have a couple of questions for you as well as for Dr. La Greca. Your paper clearly has important insights in regards to the ATA risk classification system. One is that it's prospective and validates the retrospective data. The other one is that you did an analysis by site and you incorporated in that model academic versus non-academic centers. Another factor that contributes to the results might be experience of the surgeons in regards to the volume that they are exposed for thyroid cancer management and surgery. Understanding that surgical experience might be an undisclosed factor that actually predicts some of this response to treatment. So was that considered in the model when they were trying to predict sites and response and recurrence of thyroid cancer?
This feature is indirectly addressed by this model because this mixed models is able to detect any unobserved feature. So also this point you raised. But of course, we don't have direct data addressing your question, and we didn't collect this information in our database. So I'm not able to address specifically this point, which is important.
And thank you, Cosimo. One question from the audience is: do you see, because you have been collecting cases and for so many years now. Do you see any time dependent effect of the ATA guidelines being released in 2015, 2016 with the rate of new lobectomies or the rate of lobectomies before and after?
Today, I don't have data to answer to this question, but this is a good point, and actually we are trying to analyze because we started this database in 2013, and now the follow-up is increasing, and we may have data to address specifically also questions like this. But today I am not able to provide evidence-based answer based on our findings.
Thanks. Dr. Greca, one criticism for the ATA risk classification system is that it puts in buckets certain characteristics of the tumors that we know that it actually behaves more as a continuous risk classification. I think the bucket classification is helpful, but we understand that between low and intermediate risk, actually we have those ones that live between, and we also have those cases that live between intermediate and high risk. So what do you think is the future for the risk classification to trying to give some more granularity about those cases? Now, you know, we have been able to put patients in different buckets. So what is next?
Yeah, so that's a great point. And if you think about it, you know, now that the micrometastasis of on lymph nodes, if they call that low risk of up to 5 lymph nodes on the central neck of 0.2 centimeters or 2 millimeters, that I haven't seen any patient that qualifies for that. So it's a totally arbitrary measurement that the committee of the guidelines decided to draw a line. And we are not sure if having a feature of intermediate risk and a feature of high risk would put that patient at double the risk, or is that adding more? So I think on the future of this, I see a few things, and it's going to take a few years, but the addition of the molecular marker information, the mutational profile of the tumor is going to add a lot to that, and that's going to take a lot of years because of the price, of course. In the US, there's a lot of companies now that offer that for free, especially the companies that sell the drug to target those mutations. And then I think the information about the local regional disease is going to relax a bit on the exact definition of that. But again, we are very clear on what is high risk. We are quite clear on what is low risk, and this whole gray area of intermediate risk, I am not sure if we're going to be able to qualify that better, and those are the patients that the whole team is always debating, are we giving this radioactive iron? I think in the future, we know that a high percentage of these intermediate risk patients are not going to need aggressive therapy, are not going to need radioactive iron, may be fine with just a lobectomy, as we keep understanding the natural history of thyroid cancer without so much intervention.
Thank you, Amanda. One last question. We only have a couple of minutes, but I find that there is a paradox here in that we are doing more lobectomies for the majority of these patients, but yet the risk classification and response to therapy seems that doesn't fit very well with patients that have lobectomy, because all thyroglobulin is no longer reliable. All of those will be biochemical incomplete. There might be some structural disease that is difficult to assess. So what do you think is going to need to happen there to better help clinicians and patients for those cases in which we decide for lobectomy?
I think the decision for a patient to be less aggressive and the decision to do a lobectomy requires the initial evaluation to be very thorough. Once you decided to do lobectomy on a patient, it's usually a low-risk patient because you are not seeing exothyroid extension, you're not seeing clinically significant lymph node metastasis. So I think your main chance of having a good outcome on a lobectomy is at the decision of the legs extent of the surgery. As for follow-up, of course you can rely on thyroglobulin, and we rely a lot on the imaging study, especially in neck ultrasound. But again, we are talking about lower risk thyroid cancers. And as we said before, you do need good skilled ultrasonographers to follow that up. So if you're going to indicate a lobectomy for a patient, then you need to have a plan to have a surveillance on this patient. You should rely on that. So if you have a good ultrasonography, if you know how to read ultrasounds, but again, the decision to do that type of partial thyroid surgery, it's at the beginning of your assessment of the disease. You could be wrong on very, very small percentage of cases, but the ones that you decide to do lobectomy are usually low-risk thyroid cancers, less aggressive.
Yep. Fantastic. And again, thank you very much, Dr. Durante and Dr. Greca, for those wonderful presentations. I would like to thank everyone for joining us and hope they will join us next week. We have a wonderful presentation also already scheduled for next week, and we have to remind everybody the first tumor board with Dr. Mike Tuttle by the end of April. Thank you, everybody.
Thank you so much.
Thank you.